Hi guys, welcome back. The topic next up is acute kidney injury, and the first reason why we're studying this is because this can complicate as much as 30% of all intensive care unit admissions. The person could have been admitted into our ICU, maybe post burns or acute pancreatitis. He could have suffered from myocardial infarction, went into left ventricular failure, developed a cardiogenic shock, and then subsequently the kidney got involved. But almost 30% of all ICU admissions are having on the admission sheet written acute kidney injury. Now, the second reason why studying this is before I describe the staging is these two peculiar terms because we read words like community acquired pneumonia, we read terms like hospital acquired pneumonia, but in the current edition of Harrison is mentioned community acquired AKI, hospital acquired AKI. So just make a quick go through this data for community acquired acute kidney injury. Pretty straightforward. If a person suffers from burns, or let me say a child is suffering from cholera in a village, IV fluids were not available at primary health center, community health center, the child can land up in severe volume depletion causing renal failure. Apart from volume depletion, because from the non-communicable diseases perspective, diabetes mellitus and then coronary artery disease are increasing in our country. So if a person is having, let me say, ischemic cardiomyopathy, why ischemic cardiomyopathy? Because this person was having triple vessel disease, and I had advised him to undergo a coronary artery bypass grafting. But as our patients usually keep on postponing it, so the chronic damage to the heart because of ischemia, because of hypoxia caused by ischemic cardiomyopathy, and once the heart will fail, then the kidneys can also be compromised. Then could be adverse impact of medications. The medications that I'll explain to you at the moment would be like ACE inhibitors, because hypertension is again so common in Indian population, both in urban and rural India. So adverse effect of medications could also result in AKI, because when it comes to ACE inhibitors per se, they are going to cause a dilatation of the efferent arteriole. You see, the balance between the efferent and the efferent arteriole helps in maintaining the glomerular filtration rate. If you dilate the efferent arteriole, then that filtration pressure or the gradient across which the filtration has to occur tends to reduce, and therefore adverse effect of medication, in a sense that maybe this chap was having bilateral renal artery stenosis and the doctor had prescribed ACE inhibitors, then there could be acute kidney injury developing in the person. Next up would be a patient who is having benign prostatic hyperplasia. I'm trying to write down a cause which would be classified as a post-renal cause of acute kidney injury, like a patient of BPH. If he doesn't get treated by medicines or by surgery, there's no TURP done, no medication being given, then obstructive uropathy could again result, or obstruction of the urinary tract can cause a post-renal cause of acute kidney injury. Though other causes could also be there: bladder outlet obstruction, bilateral ureteric fibrosis due to connective tissue disorders like scleroderma. But one of the leading reasons why you could have a post-renal variety of acute kidney injury and obstruction of the urinary tract would be benign prostatic hyperplasia. Then obviously malignancy could intervene and could contribute to this kind of a presentation. In contrast, when he says hospital acquired acute kidney injury, you see why I'm talking about this is traditionally we read pre-renal, renal, post-renal, and here in the textbook he's talking about a hospital acquired situation. So this would most of the time be sepsis. I mean, the person could have acquired this infection in a hospital setting itself. He was admitted for some medical disorder, and then from the hospital's environment he got infected. He went into septic shock, and that can cause ischemic damage to the kidney tubules, and the reactive oxygen species which are produced in sepsis, the cytokines which are produced in sepsis, can cause a hospital acquired injury. And similarly, if a person is undergoing any major surgical procedure, in all major surgical procedures, there is a possibility that the procedure might go for a longer duration than what it was planned. Most of the time, when we are posted in the OT, we see that surgical procedures might be taking longer than what was planned for them. Not that the surgeon is inexperienced, it is simply that intraoperative complications were occurring and the surgery took a longer time. If surgery will take a longer time, the anesthesiologist will have to give anesthesia for longer duration, and all anesthetic drugs are vasodilators. And because they dilate, they're the reason why, I mean, once they dilate, there could be decreased perfusion of the kidney, which will explain renal failure. If he asks you in the exam from the physiology perspective, which is the most vulnerable part of the kidney, which is vulnerable to hypoxia, susceptible to hypoxia, then you see outside part of the kidney's cortex, medulla is deeper inside, so medulla will be more vulnerable. And then he will also give you options like outer medulla and inner medulla. Then answer it as outer medulla. I repeat once again, the most vulnerable part of the kidney, susceptibility to hypoxia, vulnerable part of the kidney to hypoxia is the outer medulla, and that is where the S3 segment of proximal convoluted tubule is, and prolonged anesthesia would contribute to exaggerated vasodilation of the renal vasculature, decreasing the perfusion of the outer cortex, and thereby the kidneys can fail. So we are gonna subsequently discuss regarding the pre-renal, renal, and the post-renal causes. But at the moment, he's mentioned a couple of them as community acquired, hospital acquired, artificial classification. But because it is given, that is why it has been discussed at the moment. And our next focus would be to talk about the staging of acute kidney injury. Just like I've talked about stages with respect to chronic kidney disease, that would be categories of GFR from G1 to G5. We are now going to talk about stage 1, 2, and 3 of acute kidney injury. When I was a student your age, I used to read the word acute renal failure. Now they say the word acute kidney injury. You see, we are trying to go for an early diagnosis. First you have an injury, then you have a failure. First organ damage will occur, injury, then failure will occur. So because we want to make an early diagnosis, now we don't wait for the kidney to fail. We want an early diagnosis. So that's why the word used is acute kidney injury. And I'm going to describe before you for acute kidney injury the 3 stages. And the parameters which are going to be used here is one, obviously serum creatinine. Serum creatinine can be normal also in people who are having less muscle mass. Or let me say a person is already having CKD and he's having an acute kidney injury superimposed on the chronic kidney disease. Most patients are CKD because they have a lot of catabolism in the body. Their body weight is lesser, muscle mass is lesser. So the creatinine values can be falsely normal in a CKD patient. So we will see here how would we pick up acute kidney injury superimposed on a chronic kidney disease, because the chap's serum creatinine was already on the lower side. It was falsely normal because he was having muscle catabolism. So let's look at what's the strategy that we're going to deploy. And obviously when the kidneys will fail, we'll check out the urine output of the individual. Normal urine output is 1 ml per kg per hour. And now we are going to talk about what's going to happen when the person lands up in stage 1 of acute kidney injury. The serum creatinine will obviously jump up. So you will answer 1.5 to 1.9 times elevation of serum creatinine. The urine output of this patient will decrease by approximately 50%. From 1 ml, it's down to 0.5. So your answer would be, with the kidney output decreases and the serum creatinine jumps up from 1.5 to 1.9 times. If this is happening for a duration of approximately 6 to 12 hours, then you will say person has gone already into stage 1 of acute kidney injury. For stage 2, I usually do not find people making a mistake. Why? Because stage 2 would be having approximately 2 to 2.9 times elevation of the values of serum creatinine, that is over the baseline normal values. So if you just focus on the number 2 and 2, it's very unlikely that it would be asked in the exam, or you are unlikely to forget it. So that's why I think the examiner would not put it, because it's a 2 times elevation seen with the stage 2 of acute kidney injury. At this point of time, again, the urine output is already reduced, that is 0.5 ml per kg per hour. But this time the cutoff that will be used would be more than 12 hours. So again, 6 and 12 numbers, if you remember, it is still relatively easy to remember. And when it comes to stage 3, again, I think that it's unlikely to be forgotten, because stage 3 of acute kidney injury would be when you have at least 3 or more than 3 times elevation. So if he is going to ask you this table, most of the time he is going to ask you stage 1. Why? Because stage 2 would be having at least 2 to 2.9 times. Stage 3 would be having at least a 3 times elevation of the value of serum creatinine. And now there is a slight variation in the data. In the previous 2 columns or rows, I was mentioning 0.5, now mentioning 0.3 ml per kg per hour, lasting for a duration more than 24 hours is when I'm going to say that the person has gone into stage 3 of acute kidney injury. Another aspect that is described for stage 3 is that if the absolute value of serum creatinine, like he's saying that instead of having a serum creatinine jumping 3 times, because lots of time baseline serum creatinine value will not be available to you, because that's more of a Western concept, no, that the person is already having a previous KFT done. If a person presents with serum creatinine in the casualty with a value of more than 4, and simultaneously in the person the urine output is down to less than 0.3 ml per kg per hour over 24 hours, you will say that the person has gone already into stage 3 of acute kidney injury. Or if a person is already on renal replacement therapy, that is, he's already put on hemodialysis, The type of hemodialysis that we could be doing is intermittent hemodialysis, or it could be a continuous venous hemofiltration. I'll tell you the differences between intermittent hemodialysis versus continuous venous hemofiltration towards the end of this video. But at the moment, if somebody is already on renal replacement therapy, the commonest type of renal replacement therapy in chronic kidney disease is kidney transplantation. But when it comes to acute kidney injury, it's mainly hemodialysis, which would be required maybe a couple of times, and that the kidney has great powers of healing. There's another entry which is just being mentioned for the sake of formality. This is a pediatric domain, that if the age of the patient is less than 18 and you are able to determine that the estimated GFR of the person is less than 35 ml per minute, there are various methods for calculation of estimated GFR, like CKD EPI equation, MDRD formula, or the old one is Cockroach-Gold formula, by which the estimated GFR of the patient can be found out. As far as stage 3 is concerned, I think it's pretty sorted, not too much of data to remember. 3 times elevation or an absolute value of more than 4, or hemodialysis started in a person is stage 3. For stage 2 also, there is very unlikely that you would ever get it wrong, because 2 times elevation in stage 2. But for stage 1, I would like you to remember an additional aspect, which is like this. I was telling you that a lot of patients of CKD who are already having a less muscle mass could be having a normal or even less than normal value of serum creatinine. Now, suppose somebody who's already having a normal or less than normal value of serum creatinine, if he goes into renal failure, how would you pick up that this guy, he's having a less renal reserve? That's understandable, because CKD patient, less renal reserve. But if he goes into acute kidney injury, the serum creatinine will still rise. It was less than normal, it will rise to normal. It will not go to 1.5 to 1.9 times. See, serum creatinine lower limit, let us say, take a lower limit of 0.8. If a person with CKD is already having a falsely low value of 0.8, or let me say 0.7, just to exaggerate this, because of less muscle mass, if it will increase from 0.7 to, let me say, 1, it will look like normal to you only. So he says that in those patients in whom the renal reserve is lesser, if you have an increment of 0.3 milligram per deciliter over 48 hours. So for stage 1, you have a little more of data crunching to be done. Standard data is 1.5 to 1.9 times elevation, kidney output decreased by 50%, the urine output. The additional details is a hike of 0.3 milligram per deciliter over 48 hours, especially in those patients who are having a decreased renal reserve, would indicate the person has gone into acute kidney injury. Why this additional information or this additional point was added in the classification was mainly to pick up AKI developing in patients who are having a chronic kidney disease and a severe catabolism present. So once you get the table right, our next objective would be talk about that why should we, we call ourselves as, a medical field is always advancing. So we say that, okay, we are a very evolved field as compared to other fields. We doctors are always proud of our, the hard work that we do. So, a patient's relative might ask you that, sir, you're going to wait for 24 hours to tell me that my dad's kidneys are filled. He came to you relatively earlier. His dad's urine output is substantially reduced, and that guy is challenging your wisdom by saying, sir, you need 24 hours to tell me that my dad's kidney has failed, or why should you take 6 hours? Like you see, suppose we take a myocardial infarction. In MI, we would like to make an early diagnosis. Similarly, acute kidney injury. MI is acute event, acute kidney injury is acute event. So his son and daughter who's educated is asking you that, sir, why should I have to wait for so long before I am able to know that the kidneys of my dad have been compromised? Don't you have tests available by which you can make an early diagnosis? So what I'm going to do next is tell you regarding a couple of novel biomarkers. Just like I've taught you regarding biomarkers which we use for identification of myocardial infarction, like heart fatty acid binding protein, HFABP. Heart fatty acid binding protein tends to rise by as early as 1 to 3 hours. Or I can mention another one, ischemia modified albumin. Let me just jot down the names here just for recall sake. HFABP, troponin I will rise by 3 hours, that is okay. But we are having even tests available by which we can identify MI as early as 1 hour. The name of the tests are like HFABP or ischemia modified albumin, that is written as IMA. These are tests for early diagnosis of myocardial infarction. In earlier times, like we used to study in pathology, myoglobin is the first one to rise in MI, but then we don't quantify myoglobin. So it is a couple of tests are available. The standard test asked by you, answered by you in the exam would be troponin I. In the same spirit, why I told you this in the kidney discussion is that in the same spirit, I want to pick up early, either in the urine or in the plasma of the patient. So one of the tests that you should be aware of. And when I'll write it, I'm sure that you'll say, oh yeah, sir, I've read about it. That is KIM1. The name is easy to guess also. That is kidney injury molecule 1. Once the values of this are elevated, tells you the kidneys are damaged, and you can check this either in the urine or in the plasma of the patient. So urinary KIM1 values or plasma KIM1 values would be elevated in any person who's having a kidney damage. Most of the time, if it's going to be nephrotoxins, like suppose this person was started on chemotherapy, like one of the chemotherapeutic drugs that we use is cisplatin. This is used in small cell cancer. It is used in ovarian cancers also. So if I'm having cisplatin, which is causing a tubular damage, then for early identification of this chemotherapy induced damage, I'm not talking about tumor lysis syndrome here, please be clear. I'm talking about anti-cancer drug causing a direct tubular damage, tubular toxicity, and causing a renal failure. Then in the urine of this person who's undergoing chemotherapy, to check out development of AKI, I can do a urinary or plasma, whatever is facilities available, kidney injury molecule 1 levels. When I write the next test before you and the full form of it, the first time when I also read it for the first time, I was thinking to myself, am I reading a test related to immunity, or am I reading a test related to kidney damage? I mean, look at the peculiar name, neutrophil associated. It is NGAL. It is neutrophil gelatinase. In fact, it is NGAL. So let me just write it in the correct nomenclature. It is neutrophil gelatinase associated lipocalin. I mean, first time when I read it, I thought it is some kind of test that is related to the immune system. But then I read that this is related to the kidney. They might be using a short form of for it, that is lipocalin 2 as well, or neutrophil gelatinase associated lipocalcin. This can again be checked out in the urine or in the plasma of the patient and helps you in early identification of damage. Just to give you the significance of neutrophil gelatinase associated lipocalcin, let us say a patient is undergoing a cardiopulmonary bypass. He is undergoing any procedure in which he has to be put on a cardiopulmonary bypass machine. Now, cardiopulmonary bypass machine does not have pulsatile blood flow. It has a non-pulsatile blood flow. And if you are gonna expose the kidney of a person, or this person who's undergoing surgery, his kidneys are gonna be exposed to non-pulsatile blood flow, then the vulnerable part of the kidney, the outer medulla, can suffer ischemic damage, and ischemic acute tubular necrosis can occur. Similarly, let us say a person is undergoing repair of coarctation of aorta and aortic transection. I mean, the aorta has to be clamped shortly so that you can repair the coarctation of aorta. So when you clamp the aorta, at that point of time, the blood supply to the distal organ, especially the kidney, would be hampered, and the outer medulla can again be hampered or affected. So if I want to check out that after a cardiopulmonary bypass or following a aortic maneuver where aortic clamping was done intermittently to repair any vascular disease of the aorta, if I want to pick up that during surgery probably there was some damage to the kidney, then I can do a urinary NGAL values. The next test is a new entry in the current edition of Harrison, that is SUPAR. Longish name, Supari nahi, it is SUPAR. So let me just now write down the full form of it, because lots of time these short forms are pretty irritating if they're asked. So your answer would be SUPAR is soluble urokinase. P is plasminogen activator receptor. It is soluble urokinase, plasminogen activator receptor. This would only be a plasma based test. U, whenever I'm writing U, it means urine based test, and when I'm writing P, it means a plasma based test. So we do have multiple tests available as a movement by which we can identify the damage to the kidney. 4, 5, 6 would be available only in I would say research based institutions. I mean, in America or Europe, I mean, they've started doing this novel biomarkers, and that's the reason Harrison is mentioning about it. But then 4, 5, 6 are relatively still being tested across various institutions. One of them is cystatin C. Cystatin C, guys, is present in all nucleated cells, and it's regularly, cells would continue dying in our body. Right, cells are produced, cells continue dying, nucleated cells. So cystatin C would be excreted in a steady state in the urine as well. Then apart from cystatin C, another one is osteopontin. First time when you read about this molecule, again the impression is related to the bone, but no, it's related to the kidney. Then is clusterin. So 4, 5, 6 are only for the sake of completion. I mean, I don't want you to attach too much of importance to at least the last 5 and 6. I don't want you to attach too much of importance. But yes, the names are 1, 2, 3, 4. Let's do a quick recap. KIM1, NGAL. I hope you are remembering it by now. Neutrophil gelatinase associated lipocalin. Then is super soluble urokinase, longish name, plasminogen activator receptor. And then would be cystatin C. So at least the top 4 novel biomarkers, the names of these should be you should be aware of. And then I've told you practical situations. Then where would you be requiring it? Like post CP bypass, post aortic clamping, or let me say post chemotherapy. If I want to make an early diagnosis that the kidneys are shutting down, then these tests would be beneficial. Next up, I'll talk about etiology of acute kidney injury, where we'll talk about pre-renal, renal, and then the post-renal causes. And first up is the pre-renal cause. You see on Facebook and social media and couple of apps, it is mentioned that the renal variety of AKI is the commonest one. But I'm quoting Harrison. You see, there can be difference of opinion between two textbooks, but Harrison is a standard textbook that we use. I mentioned the page number also, 2296, that states that the commonest type of acute kidney injury is pre-renal variety, that is pre-renal azotemia. And the highlight of this is that it's the perfusion of the kidney that is affected, but there is no parenchymal damage per se. Like, let me talk about intrinsic causes. Then intrinsic causes, if I say the word tubular necrosis, like ischemic tubular necrosis or nephrotoxins causing damage to the tubular epithelium or blockage of the kidney tubules by myoglobin or hemoglobin or by Best-Jones proteins. I mean, tubules are damaged, structure of the kidney is damaged, but here in pre-renal, it's only a underperfusion. The structural damage or parenchymal damage is not present. The first and the foremost cause would be hypovolemia. The examples for this hypovolemia can be diarrhea, cholera, and burns. The second important reason why this could be happening is decreased cardiac output. The example of decreased cardiac output that I can describe to you at the moment is ischemic cardiomyopathy. It can be any variety of cardiomyopathy. I mean, because ischemic heart disease is common in our country, so I'm saying persons should be undergoing at least take medicines, or if there's a single or double vessel disease, a PCIV stenting or a revascularization procedure like CABG is required. And if people do not undergo these revascularization procedures, then the ischemia of the heart causes ischemic cardiomyopathy and a decreased cardiac output, and the kidney can suffer, which would be called as cardiorenal syndrome. The next cause, point number 3, is the one which requires a bit of effort to remember. That would be decreased effective circulating fluid volume. Now, there are two examples that I'll be describing for this decreased effective circulating fluid volume. Let's take up the first scenario, which is relatively easier to comprehend: congestive heart failure. The reasons for this congestive heart failure can be manifold. It could be severe anemia, it could be alcoholic with beriberi, wet beriberi causes congestive heart failure. It could be valvular diseases of the heart. I mean, a person could be having mitral stenosis and mitral regurgitation, which could result in congestive heart failure, and thereby the perfusion of the kidneys can also be hampered, and then could be liver failure. Now, liver failure is the one which is relatively more difficult to comprehend. So let me explain this to you. What I mean by liver failure here is that the person is suffering from cirrhosis. Whenever there is cirrhosis in the liver, this cirrhotic liver will produce nitric oxide. And because of the production of this nitric oxide, what's going to happen is that it will reduce the systemic vascular resistance. And if you decrease the systemic vascular resistance, therefore the blood supply to the kidney will be reduced. You see, earlier I was telling you that if a person is having diarrhea, cholera, burns, there is fluid loss from the body, so the blood flow to the kidney is reduced. The textbook says that in liver failure also, blood supply to the kidney is reduced. The reason for that being a reduction of the systemic vascular resistance. One of the reasons why systemic vascular resistance is reduced and there's a splanchnic vasodilatation is because of the production of nitric oxide by the cirrhotic liver, which causes this splanchnic vasodilation, and therefore the kidney gets less blood supply and ischemic damage to the tubules could be occurring. The most vulnerable part of the kidney per se, as I've explained to you, is the outer medulla. I can explain this a different way. Let's assume that this chap with the cirrhosis is currently having massive ascites. Now, I want you to compare a massive ascites person with yourself. You see, in massive ascites, the fluid is wasted in the peritoneal cavity. The fluid that should be in the blood vessels, like in you and me, the fluid is in the blood vessels. This fluid is redistributed into the peritoneal space. I can casually use third space laws. The fluid is wasted in the peritoneal cavity. So if you compare a massive ascites patient with yourself, then in you, the fluid is in the blood vessels. Here it is wasted. So I can say that the effective circulating fluid volume on these patients is reduced, which reduces the blood supply to the kidney. The textbook says hemodynamic profile of a liver disease patient resembles that of diarrhea. I repeat that again. He says hemodynamic profile of a liver failure patient resembles that of hypovolemia. Why that is so is because of a splanchnic vasodilation, decrease in systemic vascular resistance, or I explained another way, person having massive ascites, redistribution of fluid. So the fluid which should be present in blood vessels is wasted. What I'm leading here is, or leading here to, is one of the very important reasons from the exam perspective from the pre-renal variety. I mean, diarrhea, cholera, burns, all these things, low cardiac output, you are not gonna, have any issues in answering that these are causes of pre-renal variety of acute kidney injury because blood supply is lesser. But you need to get a hang of the fact that liver failure would ultimately cause hepatorenal syndrome, because if the liver is failing, there's a splanchnic vasodilation, SVR is falling, renal blood flow is lesser than the kidney can fail. So per se, for this particular slide, I can say that if they ask you leading cause of development of prerenal azotemia, then leading cause is obviously hypovolemia. But from the exam perspective, because that's too easy, then this term has to be remembered by you. Hepatorenal syndrome is a pre-renal variety of acute kidney injury, and hepatorenal syndrome by itself, though it is a separate video in the liver section that I've described, I'll just mention about the two varieties of hepatorenal syndrome once again, because either of the two can be described in multiple choice questions. When it comes to type 1 hepatorenal syndrome, the acute kidney injury of the patient, like he's a liver failure patient having ascites maybe, and his kidneys have failed, the acute kidney injury of this patient is going to be persisting in spite of volume resuscitation. You see, traditionally, whenever a person is having a genuine hypovolemia, here it is redistribution of fluid, but suppose a person is having a genuine hypovolemia, then whenever you do fluid resuscitation, and simultaneously if you give diuretics also, then after fluid resuscitation, traditionally in a diarrhea patient or cholera patient, the kidney perfusion should resume. But here the AKI will persist in spite of doing a fluid. I mean, how do you make a diagnosis of hepatorenal syndrome? Is by exclusion. You give fluid resuscitation, kidney function is not picking up, serum creatinine is still getting elevated. And in this case, what you have done is, because most patients of ascites will already be on diuretics, most patients of ascites will be on spironolactone. If you use too much of spironolactone, then too much of spironolactone will cause excessive diuresis and again can cause a pre-renal variety of acute kidney injury, but that would be genuine fluid depletion, because diuretics cause a fluid loss, no? Diuretics cause a fluid loss. So what I've done is I have the withholding of diuretics has also been done by me. I said 2 points. I've given a fluid bolus and I've stopped diuretics in the patient. Spironolactone or diuretic, whatever was being used, has been stopped, and so that I can rule out that okay, excessive use of diuretic is not the reason for hypovolemia and a shutdown of the kidney. If these two causes, these two conditions are satisfied and still the kidney function is not improving, then you say it is hepatorenal syndrome type 1. This will develop very fast over a 2-week period with a progressive rise in the value of serum creatinine. So HRS is a diagnosis of exclusion. There are 2 things to be ruled out. 2 things to be ruled out basically means that hypovolemia is to be ruled out. Hypovolemia is ruled out in a sense that fluid resuscitation has been done, adequate fluid bolus was given, kidney perfusion should have taken place, and diuretics were stopped. So both of these conditions are meeting the fact that hypovolemia is not the cause and still the kidneys are failing. So we'll say HRS type 1, and he is a known case of liver cirrhosis. In type 2, however, the damage occurs progressively or gradually over weeks to months. Here I said weeks, there I'm saying weeks to months per se. So type 2 variety of hepatorenal syndrome traditionally has refractory ascites, where the person is not going to respond to the standard diuretics that you will be giving or salt-free albumin that you will be giving. Even if you do paracentesis, the fluid will come back. So here you can understand, if I say refractory ascites, the fluid is wasted in the peritoneal cavity, it should be in the blood vessels. So therefore the perfusion of the kidney has been hampered. Hepatorenal syndrome has been discussed separately in the video of the liver, so I would suggest you to go through that also, but I'm highlighting this here as one of the important causes that you should be remembering for development of acute kidney injury. So I mentioned 3 causes till now: hypovolemia, cardiomyopathy or decreased cardiac output, congestive heart failure, and liver failure. Let's look at the 4th one. Next, we'll focus on drugs which would be responsible for the prerenal variety of acute kidney injury. The baseline information is like this, that the efferent arteriole of the kidney causes vasodilation. Prostaglandins in our kidney help in this, maintaining this vasodilation and ensuring a kidney perfusion. The efferent arteriole exhibits a vasoconstriction. Imagine the kidney tubule being fed by arterioles efferent and efferent. The efferent arteriole is dilating, so more blood will go in the glomerulus, and efferent is constricted. Imagine there's a straight tube. If you squeeze it on one side, then the pressure will increase. That is what is happening. Afferent arteriole is dilated thanks to prostaglandins. Efferent arteriole is constricted thanks to angiotensin 2, and therefore in our kidney there is a creation of a filtration gradient. This is what is responsible for production of the ultrafiltrate, and if this balance, the delicate balance, is distorted, then the perfusion of the kidney will hamper. Let's see how. Suppose a individual is taking painkillers on a regular basis, that is non-steroidal anti-inflammatory drugs which are going to inhibit prostaglandin production, then not only can he be having a peptic ulcer disease, but because you want to cut off prostaglandins, then the vasodilatory activity would also be hampered. And if you reduce the vasodilatory activity, then the perfusion of the kidney, or the blood supply to the kidney, or the supply to the kidney per se, would be reduced. Let's take an alternative situation. A person is having bilateral renal artery stenosis. His angiotensin 2 is causing vasoconstriction, and if you use ACE inhibitors, you have prescribed ACE inhibitors in an individual. That's why they teach you ACE inhibitors are contraindicated in a patients of bilateral renal artery stenosis. Why? Because if you give ACE inhibitors in these patients, you will cut off this vasoconstriction, which was responsible for the filtration gradient, and again the perfusion of the kidney would be hampered. We traditionally read this data. ACE inhibitors are always contraindicated. They can be used in unilateral renal artery stenosis, but they're contraindicated in a person having a bilateral renal artery stenosis. Why? Because I explained the angiotensin 2 part, which is responsible for vasoconstriction, is gone. It will dilate, so the filtration gradient would be lost. Another point I can say is ACE inhibitors are also contraindicated in unilateral renal artery stenosis. And you will be saying, what? You just told us ACE inhibitors can be used in unilateral renal artery stenosis. Listen to the data completely. If he says person is having only one kidney, suppose a person is having unilateral renal artery stenosis and is having a solitary kidney, then in a person with a solitary kidney and unilateral renal artery stenosis, the condition is same as that of bilateral renal artery stenosis. The poor fellow is having one kidney only. That is responsible for filtration of the wastes. And if you're gonna dilate the efferent arteriole, then the bad news would set up that the kidney would fail. So this is standard data. ACE inhibitor is contraindicated in bilateral renal artery stenosis, but you also need to remember ACE inhibitors are contraindicated in unilateral when a person is having a single kidney, solitary kidney. The drugs part are mainly ACE inhibitors and NSAIDs, which you need to remember. And another drug which is to be remembered is cyclosporin. Remember my words that aminoglycosides are to be answered as an intrinsic cause of acute kidney injury. Similarly, cisplatin is an intrinsic cause, but cyclosporin is to be answered as a prerenal cause of acute kidney injury. It's not that I'm asking you to remember this data blindly. Studies have shown that it decreases nitric oxide production, which is important for perfusion of the kidney, causes production of reactive oxygen species, again, which reduce the perfusion of the kidney. So, per se, in multiple choice questions for cisplatin or for tacrolimus or aminoglycosides, you will answer intrinsic cause. But for the ones that I mentioned currently on the slide before you, you will answer it as prerenal causes of development of azotemia in a patient, which means increase in blood urea nitrogen. And the most important cause to be remembered out of all of these from the exam perspective, though number one cause is hypovolemia, from the exam perspective, the most important cause which is to be answered would be this one-liner question saying hepatorenal syndrome is an example of, and your answer would be prerenal variety of acute kidney injury. We will next talk regarding renal causes or development of acute kidney injury, which we can artificially divide this into glomerular causes, tubular and interstitial causes, and vascular one. I'll start with the extreme right hand side, and the first cause that we need to remember would be hemolytic uremic syndrome. The trigger for development of HUS is E. coli O157H7, and this organism or this bacteria is known to produce a toxin that is called as Shiga toxin. Now, the problem with this Shiga toxin is that it can activate the complement and can result in formation of microthrombi in the kidney circulation, and that explains the development of renal failure that ensues in these patients. Most of these patients initially present with diarrhea, and after 7 days of diarrhea, there is a development of this acute kidney injury because the complement system mediated damage will take some time to cause manifestations in the person. So the term used most of the time in the questions will be D positive HUS, which means diarrhea positive HUS, and a lot of these patients could even be having blood in the stools. The next cause to be remembered after hemolytic uremic syndrome is thrombotic thrombocytopenic purpura. There's a separate video recorded by me in the app itself for TTP, which has a pentad where you'll have presence of fever. I mean, that's one of the important features that would be present. Along with fever, there could be presence of anemia, then thrombocytopenia, neurological and renal failures also. There is a mnemonic by the name of FAT NRI that I've discussed in TTP, and I'm repeating the features once again for the pentad. You need to remember 5 of them here. That would be fever, anemia, thrombocytopenia. The type of anemia here is microangiopathic hemolytic anemia. And again, why this disease is developing is because of microthrombi in the kidney circulation as well as the brain circulation. And that explains why neurological features can be seen in the form of ischemic stroke and renal failure will ensue. In fact, hemolytic uremic syndrome and TTP can be, I can say, are like a spectrum disease. Like in COPD, you have chronic bronchitis, emphysema. Similarly, HUS and TTP have some common features from the pathogenesis perspective. And in some patients, you would only have renal involvement. In some patients, you would be having renal plus neurological involvement along with fever, microangiopathic hemolytic anemia, and thrombocytopenia. So I would suggest you to watch the topic of TTP as well, where microthrombi formation have been discussed. In fact, another event that I would like to add for thrombotic thrombocytopenic purpura would be deficiency of ADAM TS13. The main function of ADAM TS13 is to neutralize the activity of von Willebrand factor. You see, von Willebrand factor is produced from the endothelial cells, and it causes formation of then, or it's responsible for platelet aggregation because von Willebrand factor is like a tissue glue. It helps in platelets to stick on to the vessel wall, and to counterbalance the effect of von Willebrand factor in our body, we have ADAM TS13. Like we have clotting factors and anti-clotting factors. Anti-clottings like protein C, proteins antithrombin 3 to neutralize the clotting factor. Similarly, to counterbalance von Willebrand factor, we have ADAM TS13. If ADAM TS13 levels will become lesser or the activity will become lesser, I said two things. Either the production is lesser or the activity is lesser. As a result of it, the von Willebrand factor activity would be unchecked. That can again cause microthrombi formation in brain and the kidney circulation, causing thrombotic thrombocytopenic purpura. Then if a person is having uncontrolled hypertension, then the term that we use for this gradually increasing blood pressure, where we have damage to blood vessels. I mean, malignant hypertension would be high blood pressure with the fundus findings of like arteriovenous nipping, that is Salu sign developing in a person, or I can say that the caliber of the or the ratio between the arteries and the veins and the retina can be affected. So malignant hypertension can affect the kidneys as well. It affects the retinal circulation, it can affect the kidney circulation as well, thereby contributing to renal failure. The next condition that I'm describing before you, I'll be explaining this more in detail, this term that I'm writing more on detail in my subsequent slides. But at the moment, the heads up that I can give you at the moment is that my patient is undergoing a coronary angiography. Now, when you do a coronary angiography, you have to send up a guide wire from the aorta, and when this guide wire is navigating via the aorta, imagine guide wire traveling through the aorta and it is scraping or rubbing against an atherosclerotic plaque. Atherosclerosis can occur in abdominal aorta. The most common blood vessel of the body involved by atherosclerosis is abdominal aorta, and there's a guide wire of the angiography which is rubbing against this atherosclerotic plaque, so it can cause this atherosclerotic plaque to tear. Now, the atherosclerotic fragments that are released from this plaque would travel downstream into the renal artery and can cause blockage of the small branches of the renal artery, and therefore we call it atheroembolic kidney disease. Guys, this is a complication of angiography or any vascular procedure where you have to navigate through the aorta per se, where atherosclerotic plaque can be present. Another term that I'll be describing to you as we progress on is renal vein thrombosis. RVT is usually seen either after diarrhea. So I have written diarrhea 2 times on this extreme right hand side, and the reason why I've written it is because earlier I was telling you diarrhea contributes to pre-renal variety, but here I'm explaining to you in HUS it was diarrhea triggering subsequently because the bacteria was like a superbug. This superbug E. coli O157H7 was causing Shiga toxin production that was activating the complement and was causing microthrombi formation. So diarrhea came up again, and then diarrhea can cause dehydration in pediatric cases and cause a renal vein thrombosis. And one hint that will always be given in questions of renal vein thrombosis would be unilaterally enlarged kidney. I'll be telling you more technical details of atherosclerotic kidney disease and renal vein thrombosis in the subsequent slides as well. But all of these that I'm teaching at the moment would be vascular causes for why the kidney can be damaged. The next one that I'm writing is easy to comprehend, that is renal artery embolus. I mean, the embolus could be coming from, let me say, atrial fibrillation, or I can say renal artery dissection. So as far as the last two causes are concerned, that would be renal vein thrombosis or renal artery embolus, renal artery dissection per se. There are very less chances that somebody can forget these vascular causes that I've jotted down. Now we come to the middle of the table where I'll explain to you regarding the tubular and the interstitial damage that could be occurring, and the mnemonic for this would be SYN. By SYN, alphabet S would stand for sepsis. I mean, in sepsis, there are cytokines which are produced. There are reactive oxygen species that are produced that can cause a tubular damage. Then alphabet I would stand for ischemia, and this would be an important cause of acute tubular necrosis. Just to tell you how vulnerable the kidney can be to hypoxia, I want to tell you some figures. 20% of the cardiac output of the body goes where? It goes to the kidney. 20% of the cardiac output. Approximately 10% of the oxygen consumption of the body. Look at the figures that I'm telling you. Kidneys are going to constitute, the weight of the kidneys in our body is only 0.5% of the total body weight. I repeat once again, an organ that is so small that it constitutes only 0.5% of the total body weight. It consumes, or it gets 20% of the blood supply. So I can say, I mean, these figures that I've told you is just to sensitize you to that how well perfused our kidneys are and how important function are they performing. And if you are having a ischemia, like there is a decreased blood supply to the kidney, then the tubules would die. The best example that I can give you for ischemic damage to the kidney at the moment can be prolonged anesthesia. You see, the surgery was planned for a particular duration. The anesthesiologist will give anesthesia corresponding to the duration of the procedure. And suppose due to unfortunate complications intraoperatively, the surgery had to be prolonged for a longer duration. All anesthetic drugs are vasodilators. So when prolonged anesthesia will cause a prolonged vasodilation, the kidney will suffer, and the most vulnerable part of the kidney that I've said multiple times is the outer medulla. That's where the S3 segment of the proximal convoluted tubule is present. So ischemic ATN is an important one. And then alphabet N, I'll be spending more time on component I, and I'll be spending more time on alphabet N in my subsequent slides as well. Here I'm creating a table here before you. That would be nephrotoxins, but just to give you a heads up of what's going to come up in the subsequent slides, let me give you an example. A person underwent a coronary angiography and his creatinine was already elevated because it's a known case of diabetic nephropathy. If you fail to recognize that somebody's kidney is already damaged and you give a IV contrast or you do a contrast-based study, then contrast-induced nephropathy can develop in a patient. Though contrast-induced nephropathy has a good prognosis and the serum creatinine tends to come back by 7 days, but you can understand the amount of emotional trauma the patient and his relatives would be suffering for that particular duration, or those 7 days would be the most. The patient is going to say, sir, these were the most horrible days in my life. I was thinking that, I mean, I will require dialysis. Though I said most of the time contrast-induced nephropathy has relatively a better prognosis as compared to other nephrotoxins. Now let me describe another nephrotoxin before you, that is ethylene glycol poisoning. A person has had poisoning with antifreeze. You see, in our country it's hot, but in colder countries, if the car has to start with the first self-ignition, I mean, when you turn that self-ignition, the car tends to start. So in a cold environment, that's because in the engine there is an antifreeze agent, and this person consumed that antifreeze agent, that is ethylene glycol. It can block the tubules of the kidney. The crystals of calcium oxalate can be precipitated and can block the tubules. So lots of data is going to come up for the ischemic and the nephrotoxins, though I have described them verbally before you. And for the glomerular damage, it would be acute glomerulonephritis. So acute glomerulonephritis, and there is a possibility that person might have had an episode of rapidly progressive glomerulonephritis. So glomerulonephritis per se, various varieties of it you study in the kidney. Post-streptococcal glomerulonephritis, like I can say, in pediatric age group, it has a good prognosis. Kidney function recovers. But PSG in adults has relatively a poor prognosis, and some of these patients can go into AKI and then progress into development of chronic kidney disease as well. So the extreme left-hand side of the table is not an issue. Syndemonic will make things slightly easier for you. Sepsis, then ischemic ATN like prolonged anesthesia, patient on cardiopulmonary bypass, non-pulsatile blood flow, nephrotoxins, a couple of examples I gave to you, ethylene glycol poisoning I spoke about, and then there are large number of nephrotoxins that will be discussed subsequently, but then I did give a couple of examples. And then the vascular causes are again pretty straightforward, which could result and be defined as renal causes of development of acute kidney injury. Now, enumerating causes of ischemic injury to the tubules, we will read about burns and acute pancreatitis. I mean, traditionally, when I say burns, we always think about hypovolemia. That is okay. And even with pancreatitis, we read about development of distributive shock. So these patients were brought to the hospital on time. The doctor has started the patient on massive fluid resuscitation. So at the moment, everything looks pretty good that massive fluid resuscitation is occurring in this patient. But the bad news is that the cytokines which are released in burns patients can have sepsis, then cytokines can be released, or acute pancreatitis can be having cytokines that are released. These cytokines will cause capillaries in the body of this patient to become leaky. I can just give a parallel example like in dengue shock syndrome, capillaries become leaky. Similarly, in burns and acute pancreatitis, there can be capillaries becoming leaky, due to which, though you are doing a fluid resuscitation in this patient, this fluid could be leaking into the peritoneal space. Because of the leaky capillary, the fluid will accumulate in the peritoneal cavity and would contribute to a possible abdominal compartment syndrome. And when I write the word abdominal compartment, one question that can be asked to you is what is the cutoff at which, how much would be the pressure in the peritoneal cavity to contribute to it being called as abdominal compartment syndrome? Then there are different values given, because sometimes books will say the word intra-abdominal hypertension. Sometimes they'll just say abdominal compartment syndrome begins at the values more than 20 millimeters of mercury. And this could compromise the blood supply, because if you have increased pressure in the peritoneal space, then there would be increased pressure on the blood vessels which are supplying the kidney as well from outside. And therefore the perfusion part can be hampered, and therefore ischemic injury to the tubules could be occurring. Why I've explained this is mainly to sensitize you to the fact that this is an artificial classification that we are creating. Burns is not simply hypovolemia. In burns, we also have sepsis. In acute pancreatitis, we have a distributive shock. As a result of that, the fluid can leak in the peritoneal space and can cause compromise of blood supply to the kidney. Another reason is prolonged anesthesia that I've already explained to you. But instead of saying prolonged anesthesia, I'm writing it as prolonged intraoperative hypertension. Now, there can be multiple reasons for this prolonged intraoperative hypertension. One was obviously prolonged anesthesia. Or if a person is put on cardiopulmonary bypass, I've already told you cardiopulmonary bypass has a non-pulsatile blood flow. So that non-pulsatile blood flow will again contribute to ischemia of the outer cortex. Another example can be aortic cross clamping. The reason why we are doing a aortic cross clamping is because maybe the person had a abdominal aorta aneurysm and repair is occurring, or coarctation of aorta and the repair is occurring. But aortic cross clamp, once it is put, or if the aortic cross clamping is done during any surgical procedure, then aorta is going to be feeding the renal artery and the blood supply of the kidney can be compromised. The third important cause to be remembered here would be written as TMA. TMA stands for thrombotic microangiopathy, which means that microthrombi are developing in the kidney circulation. I have given microthrombi in the kidney circulation as the reason in hemolytic uremic syndrome also, where E. coli O157H7 was responsible. Even in TTP, I was saying ADAM TS13 activity will cause microthrombi. Now, the drugs which could be responsible for causing thrombotic microangiopathy, the important ones, though there is a list that is given in TTP video, but the antiplatelet drug clopidogrel can cause microthrombi formation. Then, though it's supposed to be antiplatelet drug, but this is a side effect which could be associated. Then antimalarial drug quinine. And the third example to be remembered is mitomycin C. Have been very selective, though the list is very exhaustive. But then these are a couple of drugs which can cause microthrombi formation in the kidney circulation. The term used is thrombotic microangiopathy, and these patients, because when RBCs, like I said, microthrombi. So when the RBCs will smash into these microthrombi, there would be structural damage to the wall of the RBCs as well, and some of these can get destroyed also. And once these RBCs get destroyed, they'll be referred as helmet cells. So microangiopathic, in the small blood vessels, microthrombi are getting formed and the RBCs are getting busted. Normally we read about RBCs getting destroyed due to autoantibodies. Here there's no autoantibody. I simply said there's like a mesh in the ultra small blood vessel in the kidney. RBC slams into it. So microangiopathic hemolytic anemia would be developing. So these are a couple of examples for the eye component of the mnemonic that I mentioned for tubular damage and can contribute to renal failure in the patient. We will now focus regarding the nephrotoxins component, which is much more interesting than the ischemic part to listen to exogenous and endogenous toxins. I'll focus on the exogenous at the moment. I'm not doing any China bashing, but then I can say that Chinese herbal medicine, though, they claim that it has a lot of curative properties for diseases which traditional medical science has no answer, but this has been documented in research papers that some of these Chinese herbs could be having a toxin which is called as aristolochic acid. And the problem with this aristolochic acid would be that it will damage the tubules, the tubular epithelium, and can cause a renal failure. So I can write the word Chinese herb nephropathy. And then I want to tell you that this component, that is aristocolic acid, is also present in some traditional medicines which are used in Europe. You see, countries that originated from former Yugoslavia, countries like Bosnia, etc., Bosnia, Serbia, for example, they are from previous Yugoslavia. So they again tend to use in their traditional medicine this aristolochic acid. And the term that is used to describe in those traditional, because of the traditional medicine used in Europe to describe the damage to the kidney, is called as Balkan nephropathy. So two terms I've described, Chinese herb and Balkan nephropathy. A lot of these herbal teas might be having aristolochic acid. Not the routine herbal tea I'm talking about, the green tea I'm talking about, but some of these, I would say, this area specifically that I mentioned, Yugoslavia and Chinese herbs, they can contribute to damage. The next one on the agenda is aminoglycosides. You all know gentamicin, tobramycin, nettlemycin. We always read about the nephrotoxicity of aminoglycosides. And the term that I want you to remember here would be non-oliguric renal failure or non-oliguric acute kidney injury with aminoglycosides. When you read it for the first time, the thought process is that kidney damage is associated with oliguria. So how is it that we are saying non-oliguric renal failure? Well, the logic here is that the aminoglycosides would be causing damage to the collecting duct of the kidney. And collecting duct is where the V2 receptors are present, which are responsible for reabsorption of water. Now the water is not going to be reabsorbed. Water is going to be lost. That's why the term is non-oliguric acute kidney injury. I explain this once again. The damage by aminoglycosides would be occurring in the collecting duct, which is a site of water reabsorption. If the area is damaged, water is not reabsorbed, and therefore you do not have the traditional oliguria that you see with acute kidney injury. The next drug that we're talking about is amphotericin B. We have a liposomal preparation available. We use it in mucormycosis. Amphotericin B again causes damage to the kidney tubules. Electrolyte imbalances associated with, it's not only a nephrotoxic drug, but electrolyte imbalances associated with this are always asked in the exam: hypokalemia and hypomagnesemia. Another drug which is commonly asked for nephrotoxicity component is cisplatin. This is one of the common drugs that we shall be using in lung cancer. The most aggressive lung cancer is oat cell cancer, where cisplatin is used. Even in ovarian tumors, this platinum-based compound is used. And the renal failure, if it occurs, then we might have to do dialysis in the patients also. Then comes the issue of contrast-induced nephropathy, CIN. Though I told you that it has a good prognosis, but let's look at the progression and how a question on contrast-induced nephropathy can be given to you in the exam. You see, this patient is undergoing, let me say my hospital on World Health Day has introduced a scheme where coronary angiography is being done free of cost or at a discounted rate, and therefore there was a rush of large number of patients. Now there was one patient who is a known case of diabetic nephropathy, and in this particular case, pre-operatively, before the procedure was done, the serum creatinine was already pre-procedure. The serum creatinine of the patient was elevated, but because there was so much of rush and I was also in rush to do all the paperwork, I neglected the serum creatinine report of this patient. A gross medical negligence on my part, but when you are overstressed, overworked, there is a possibility that you can miss out a couple of reports. This patient's kidney is already damaged. His serum creatinine is already elevated, and you are giving him contrast for angiography. Now, angiography will be done. We'll be able to determine whether he's having a single vessel, double vessel, triple vessel disease. But after the procedure is done in this patient, post procedure in this patient, the serum creatinine will show a tremendous rise. It might show a doubling or tripling depending on, I told you the classification, right? For AKI, stage 1, we have 1.5 to 1.9 times elevation. Stage 3, we have 3 times elevation. So serum creatinine of this patient will jump post procedure. Most of the time, the rise in contrast-induced nephropathy is seen after 1 to 2 days of the procedure. The peak values of serum creatinine are obtained by 3 to 5 days, and then the values tend to stabilize or there's a plateau in the curve, and most of the time the resolution will occur by the 7th day. But the patient obviously is not going to like it, and neither is relatives, son and daughter. They're going to make life miserable for you, and the patient is going to say, doctor, how could you allow me to undergo a procedure when my kidney was damaged? So the point is, contrast induced nephropathy, one, what they can give you is the situation that person has undergone a study and his serum creatinine has shown a tremendous jump. It was already elevated, it's shown a tremendous jump subsequently. And what you are going to do in these patients is that for management of contrast induced nephropathy, I'm mentioning the treatment part here only, though the treatment of AKI will be discussed separately. But for contrast induced nephropathy, you need to ensure hydration, you need to ensure good perfusion. So we usually tend to add soda bicarbonate to the IV fluids, and along with that we use N-acetylcysteine. Though you will have people saying that okay, N-acetylcysteine was used formerly. Yes, there are a couple of research papers that say that N-acetylcysteine will not produce very good results, but that's one of the drugs that is used even now in the 21st edition of Harrison. I'll have to mention the page number also, otherwise the controversy will come that, sir, one teacher told us that there is no role of N-acetylcysteine now in contrast-induced nephropathy. We have to go by standard textbooks and not by research papers. In the current edition of Harrison, mentioned the page number as well, it's written clearly that N-acetylcysteine is used in management of contrast-induced nephropathy. The results may not be as accurate as we think it to be, because the logic here is N-acetylcysteine, it does bring down the serum creatinine value back to normal, but it does not improve GFR. What he says is that N-acetylcysteine does not improve the GFR, but tends to, metabolize serum creatinine, and therefore the serum creatinine values tend to become normal. But there is no point of going into controversies with respect to research papers, so I thought I should mention it. And then another important cause that I would like to mention here before you, for the exogenous perspective, would be the antifreeze agent, which I described before you was ethylene glycol. Now in the exam he has asked us that in ethylene glycol poisoning, why would the person end up with acute kidney injury? Then your answer would be that ethylene glycol poisoning will cause precipitation of calcium oxalate crystals in the kidney tubules. Because of these crystals that have shown blocking the kidney tubules, the tubular function will be hampered. The ultrafiltrate progression into the distal tubule collecting duct would also be hampered. The urine output will also fail. Yes, fomepizole, the antidote that we study for methyl alcohol poisoning, is the same, is going to be answered as antidote for ethylene glycol poisoning also. The next cause that I'm telling you, this hit the reputation of Indian pharmaceutical industry very hard. You see, India is one of the main exporters of medicines like cough syrup, etc. to Africa and even to Central Asia. Now, in an African country, that's Gambia, and then even in Central Asia, I think it was Uzbekistan, a couple of children who consumed cough syrup manufactured by an Indian pharmaceutical company. I think it was a North India, Haryana-based company. And children who consumed cough syrup manufactured in this company in Central Asia, they died. So the WHO had also put up a warning notice, sent a couple of representations to the Indian government to improve quality control in these pharmaceutical companies where bulk production of cough syrup would be occurring. So I'm going to tell you about a toxin which could be due to contamination during the manufacturing process, and the name of the product is diethylene glycol. Earlier, I was talking about ethylene glycol. Ethylene glycol is the antifreeze which is present in the car radiator and helps the car to start with the first turn of the self key in a very cold environment. But currently, I'm talking about contamination. This causes pharma product adulteration. This pharma product adulteration, was present in the cough syrup. Children consumed that cough syrup and they developed metabolic acidosis, they developed hyperkalemia, they developed anuria, and standard features of acute kidney injury were present in these cases. So, what I've described before you are a couple of exogenous causes of acute kidney injury. We'll now focus on a couple of endogenous causes why this could be happening. The first one to be remembered is this guy was crossing the road when a truck or a heavy vehicle went over the legs of this guy, that is crush injury. So rhabdomyolysis can contribute to myoglobinuria, and this myoglobin being a high molecular weight compound will block the tubules of the kidney, and thereby the kidney function can be hampered. Instead of talking about a crush injury or an accident case that I was describing, I want you to remember that prolonged immobilization. Routinely, we read that prolonged immobilization is a risk factor for deep vein thrombosis, and then there could be clots going up to the lungs, and there's a pulmonary embolism. But today, I'm telling you that prolonged immobilization can cause compression of blood vessels and reduce the blood supply to the muscles. The CPK-MM values will rise, and rhabdomyolysis or myoglobinuria can be occurring in a patient. He can also give you a situation where a person has developed status epilepticus. Prolonged seizures can also contribute because the muscles are, in the clonus phase, they're working over time, then muscle damage can occur, and that can explain rhabdomyolysis in a patient. So is the situation with heat stroke. And then from pharmacology, I'm writing malignant hyperthermia. You read about the treatment for malignant hyperthermia is dantrolene sodium. You read about ryanodine receptors causing abnormal calcium influx, and malignant hyperthermia would be seen with inhalational anesthetics and even drugs like succinylcholine. The inhalational anesthetic with which malignant hyperthermia is seen is halothane. You read about in anesthesia as well. So don't only think in terms of crush injury. Prolonged immobilization, seizures, heat stroke, and then malignant hyperthermia can cause muscle damage. Myoglobin being a high molecular weight compound, just for symbolic representation, it's gonna block and clog the tubules. Tubular cells are not damaged. Tubular cells are not damaged, but there's a clogging of the tubules. The tubular function is hampered, and thereby the urine output of the person will be hampered. So the first example that I explained to you was rhabdomyolysis. Now let us imagine patient's blood group is B positive and he was given A positive blood. No doctor will ever make that mistake. Most of the time, this is a clerical error that the unit of blood that you were giving to the patient was having a wrong label. Because of this wrong labeling, you thought, okay, whatever the blood bank officer has written would be correct and countersigned by him. But when you give this blood to the patient, if there's a mismatched blood transfusion, then it's going to cause type 2 hypersensitivity and the RBCs will get destroyed. And once the RBCs are destroyed, hemoglobin, which is inside the RBCs, will now come in the urine of the patient. The person will start having hemoglobinuria. If a person undergoes a blood transfusion and then starts having a flank pain, he starts passing a black color urine, and then the kidney shutdown occurs, it means that there was hemoglobinuria. Hemoglobinuria, just like myoglobin, will clog the kidney tubules and contribute to renal failure developing in the patient. The next patient of mine is having, let me say, a high-grade lymphoma like Burkitt's lymphoma, or he's a patient of acute lymphoblastic leukemia. The condition that I'm teaching at the moment is called as tumor lysis syndrome. First one, they will ask you what is the cause of tumor lysis syndrome. Then these cells or these cancers that I'm describing before you at the moment, like Burkitt's lymphoma or leukemias like acute lymphoblastic leukemia in children, acute myeloid leukemia in adults, they have a high cell turnover rate. Because of the high cell turnover rate, large number of cancer cells are present, and when you will start chemotherapy in these patients, the moment you start chemotherapy, you will kill all these cancer cells, and killing of these cancer cells will cause uric acid levels to spike. The reason for that being, all cancer cells will be having nucleus. All cells have nucleus, and this nucleus would be having purines, and the end result of purine metabolism is uric acid. So what you're going to have is post chemotherapy in the patient, the uric acid values will begin to spike, and I can say that these uric acid crystals will start blocking the tubules of the kidney, and once again the kidney function would be hampered. You were trying to do good for the patient by initiating chemotherapy, but the bad news is that uric acid crystallization will cause hampering of the kidney function. And apart from this, multiple other electrolyte imbalances can be present in tumor lysis syndrome as well. Now, the mnemonic that we can use to remember the manifestations, the electrolyte imbalances that can be seen with tumor lysis syndrome can be puke calcium. You see, all cells are having energy, right? ATP. And when the cells will die when you give chemotherapy, then it will contribute to hyperphosphatemia in the patient. Alphabet U would stand for increase of uric acid. Where would this uric acid be coming from? It would be from increased DNA breakdown, because purine breakdown would be contributing to this. Then K would be standing for hyperkalemia. That's understandable because potassium is mainly intracellular. Potassium in the blood is only 3.5 to 5.5. Inside the cells is about 150 milliculents, because potassium is mainly intracellular. And when you kill these cancer cells, then potassium values in the person will begin to rise. Over and above this, the another manifestation that would be seen would be that phosphate will begin to chelate with calcium, and therefore calcium values will become lesser. So in tumor lysis syndrome, calcium mnemonic is just a hack to remember it. Otherwise, the main things which are getting increased here are phosphate, uric acid, and potassium, and the component that is getting reduced would be calcium. The best way to prevent tumor lysis is to ensure adequate hydration of a patient. So before starting chemotherapy, you should start the patient on normal saline and ensure good diuresis. You should ensure good kidney output. You should ensure that the tubules should be properly flushed, so that the chances of development of tumor lysis syndrome can be minimized. But sometimes, in spite of you doing hydration, adequate hydration, ensuring good urine outflow, still tumor lysis syndrome can occur after giving chemotherapy in a person with, let me say, acute lymphoblastic leukemia, because the cell counts are so high. When you kill those millions and trillions of cancer cells simultaneously, then the death of these cells can cause the kidney tubules to clog up because of increased uric acid. And what you will do in this patient would be, again, you will give IV fluids. Along with IV fluids, you will have to give furosemide so that you can ensure diuresis in a patient. Bolus shots of 200 milligram, then subsequently drip of furosemide can be started. And along with this, you will have to use drugs. Now, whether in the MCQ should you answer allopurinol or should you answer rasburicase, that depends on case to case basis. In a sense that if a person is having a high grade tumor, then it is rasburicase. If it's not having a high metabolic rate or doubling time, then you can use allopurinol as well. The way I've written the data, if it specifies per se, then what is the drug of choice, then answer is rasburicase. And if he specifies per se the word high grade tumor, then again rasburicase should be answered. This is a quick reference to just show you that for high-grade tumors or high-risk situations like Burkitt's lymphoma or ALL, we'll be preferring rasburicase. Otherwise, we can be using even allopurinol in the patient in an intermediate risk situation. Now, next up would be to talk about atherombotic kidney disease. I did speak about it as a vascular cause for development of renal failure. And at the moment, what I'm showing before you in this diagram is that the person's aorta is having an atherosclerotic plaque, which is shown in yellow. And then you can visualize a guide wire. I mean, I'm planning to do a coronary angiography of the patient. So my guide wire will go up like this retrogradely towards the aorta, so that we can reach the root of the aorta, because that is where the coronary arteries are. But when your guide wire is going in this direction, it can scrape against the atherosclerotic plaque. Because of this, there could be some fragments created. I'll just use the same color. Like this atherosclerotic fragments have been created because of the damage to this atherosclerotic plaque, and they can travel into the renal artery of the patient and then go into the smaller branches and can cause a vascular damage, because the blood supply of the kidney has been hampered. In this case, it's blocked by these cholesterol emboli. Therefore, we call it atheroembolic kidney disease. Why I chose a diagram to represent this is that in these patients pre-procedure, the serum creatinine was perfectly normal. Like in contrast-induced nephropathy, I was saying person's serum creatinine was already elevated, his kidneys were already damaged. In a person who's having atheroembolic kidney disease, prior to the procedure, like this guy is scheduled for a coronary angiography, his serum creatinine is gonna be perfectly fine. But after the procedure, we can have a renal shutdown, and the serum creatinine of this patient will become double or triple depending on the kind of stage that he lands up in. The message here is that he can give you two questions. In a question related to coronary angiography complication, there can be two possibilities. Either it will be contrast-induced nephropathy or it's going to be atheroembolic kidney disease. Now, how would you differentiate? One way to differentiate is that he gives you a pre-creatinine and a post-creatinine value. But suppose, because it could be a 3 or a 4 liner question, and by the time you're on the 4th line, you might be forgetting what the initial creatinine value of the patient was. So I'm going to give you some hacks by which you will be able to crack it immediately, because the moment you would be having cholesterol embolism, these cholesterol fragments would spread all over into the body. So he could also mention post procedure in the person. Not only a rise of creatinine and acute kidney injury, he would also be mentioning development of livedo reticularis. Then a urine examination finding can also be given in the patient, that is eosinophiluria. Obviously, you need to remember the entire domain that I've said, that after angiography or any contrast based study, if the creatinine of the patient becomes double, triple, urine output becomes less than 0.3 ml per kg per hour for 12 hours or going up to 24 hours, and along with these terms are mentioned like livedo reticularis and eosinophiluria, then you need to think in terms of atheroembolic kidney disease. Now compare this with what I tell you next, that is acute interstitial nephritis. For acute interstitial nephritis, he will give you that the person was on the following drugs. It could be like vancomycin, it could be methicillin, and what I'll say next will shock you. Person could be on something as simple as proton pump inhibitors, or could be on NSAIDs. Earlier, I was telling you that NSAIDs can contribute to efferent arteriolar, prostaglandin production is responsible for efferent arteriolar dilatation. But now I am blaming NSAIDs not only for causing a prerenal variety, but they can even cause an acute interstitial nephritis. Now, what would be a triad that would be described in the question is that this person is on following drugs. So, not only could he give you a scenario of nephrotoxic drugs like cisplatin and aminoglycosides, but he can also mention something which looks very benign and harmless like PPIs, or I can say methicillin, vancomycin, which are regularly used. The person will end up with fever. Along with that would be acute kidney injury. There would be a rash in the patient, and urine microscopic examination finding of eosinophiluria will be present. That is again a very, I would say, atypical term that I'm writing. We read hematuria, but I've taught you two MCQs at the moment where eosinophiluria will be present. This could be a 3-liner, 4-liner question describing renal function compromise, rise of serum creatinine in the patient. Prior to the intake of drugs, serum creatinine is normal. Now the serum creatinine is rising. But two questions where eosinophiluria is to be remembered is one, atheroembolic kidney disease, and second is acute interstitial nephritis, which is the reason why this particular slide is important. The third one is contrast-induced nephropathy. Whatever I'll say is a repetition for contrast-induced nephropathy. Pre-procedure in this patient, serum creatinine was already elevated, but it was a negligence on my part that I did not check the reports of the patient properly and scheduled him for a contrast-based study. Once the procedure has been done, the contrast-based study, the serum creatinine of the patient will become double and triple. He'll describe a rise of over 1 to 2 days, peaking by 3 to 5 days, falling back to normal by the 7th day. So you'll get a good idea regarding the presentation per se. And even in this question, because coronary angiography has also come up 2 times. I am repeating this fact once again. Complications of coronary angiography. One I've taught you is, obviously coronary angiography contrast-based study can cause a renal failure. But that renal failure, what should you answer? Should you answer CIN or should you answer atheroembolic kidney disease will be on the basis of aspects that I've highlighted. Like if in the exam there's a pressure and you're not able to, correlate the pre-values and the post-values, then my suggestion would be to look for words like livedo reticularis and eosinophiluria, which helps you in diagnosis of atheroembolic kidney disease. Otherwise, it would be contrast-induced nephropathy. Another cause that I'd spoken about in the vascular causes for development of acute kidney injury was renal vein thrombosis. Let me just try to explain this to you as well. Let us assume this is the renal artery, and then the blue is the representation for the renal vein. And unfortunately, my patient, I'll tell you reasons also why there's a clot, but at the moment, just imagine there's a clot in the renal vein. Now, the problem here is that the blood will be able to flow from the renal artery towards the vein, but then there's an obstruction present. And because of this obstruction, the size of the kidney will increase. You'll have a unilaterally enlarged kidney developing in a patient suddenly. The history given in the question would be that the person that was mainly a child who suffered from diarrhea and developed dehydration. This dehydration can result in development of then a renal vein thrombosis. If he's going to give you a question on an adult, then he's going to describe that this person is having one of the causes of nephrotic syndrome, that is membranous glomerulopathy. So he's initially going to tell you that this person could be positive for anti-phospholipase A2 receptor antibody, which is one of the causes for MGM. And now these patients, the same patient on nephrotic syndrome / a child with diarrhea, they will be having a renal shutdown, they'll be having his acute kidney injury, and you would also be having unilateral kidney enlargement. You can have a unilateral kidney enlargement with hydronephrosis. That is okay, but you don't have a renal shutdown. I mean, you don't have a AKI with hydronephrosis. No, hydronephrosis can occur due to bladder outlet obstruction. It can occur due to ureteric fibrosis. The kidney will be enlarged on one side, but you do not have acute kidney injury. So, especially if it describes a question where diarrhea was the trigger and then there was a kidney injury in a person, initially you will think diarrhea is causing AKI. Fine, man, pre-renal. What you can miss is what I've written at the moment. I repeat that again. Diarrhea can contribute to AKI. We all know that. But if it's a diarrhea-induced AKI, then kidney size remains normal. If he says that there is a unilateral kidney enlargement, that means there is kuch to gadbad hai, right? That is renal vein thrombosis. The investigation that we do for renal vein thrombosis, if he says what test would you do, then we'll do a renal angiography. But you can very well understand renal angiography may not be available all the time. So the first investigation to be done will be Doppler. If he asks you to select between the two, then obviously what I'm saying is first to be done is Doppler. First to be done for diagnosis of renal vein thrombosis is a Doppler, but in obesity situation, in child who's non-cooperative, Doppler would not be having a high yield. So, for any vascular condition, angiography will always be preferred. So, if he says investigational choice for renal vein thrombosis, it is renal angiography to be done. And the problem with renal vein thrombosis is that the clots can move up to the lungs and can have even pulmonary embolism. So if you're listening to me carefully, I've described diarrhea in two situations before you. One for E. coli O157H7, which were causing microthrombi due to Shiga toxin causing complement activation, and then diarrhea is causing renal vein thrombosis and is causing a unilateral enlargement of the kidney. So every time you are having a renal failure with diarrhea, don't think of the standard pre-renal one. Think of these two causes as well. Similarly, if he talks about, let me say, coronary angiography, then you need to think in terms of athrombotic kidney disease or contrast-induced nephropathy. I've already given you hints. I'm repeating that again. I mean, this slide will be a repetition. I could have avoided doing this slide with you, just saying that, okay, I've already told you this. But then I find people make mistakes in questions. So I would request you to remember this. And eosinophiluria is also to be remembered for acute interstitial nephritis, where there was drugs being used and then there was a renal failure. And those drugs were not like the traditional highly nephrotoxic drugs like tacrolimus or natilmycin, tobramycin that we study. I mean, it was something like PPI or NSAID, which was causing fever, rash, and then acute kidney injury in the person. We shall now talk about the post-renal variety of acute kidney injury, which I think is the easiest one to identify, and we can do an ultrasound abdomen to identify it. The first and the foremost cause to be remembered would be benign prostatic hyperplasia that will cause an obstructive uropathy, or a person could be having a bladder stone or a tumor in the bladder, which could be contributing to bladder outlet obstruction. And then there could be causes with respect to the ureter as well. Now, if a person is having a ureteric fibrosis on one side, the chances of development of acute kidney injury would be relatively lesser. So I'll be jotting down here conditions where you could have is a bilateral ureteric fibrosis and then a complete renal shutdown, like scleroderma is a connective tissue disorder where we have anti-topoisomerase antibodies, and bilateral ureteric fibrosis is documented. Or drugs which can contribute to bilateral ureteric fibrosis would be bleomycin. I'm not saying that stones cannot occur here or tumors cannot occur here. I mean, that's pretty understandable. Bilateral ureteric stones or bilateral ureteric tumors can contribute to it. But then connective tissue disorder, bleomycin should be also remembered. And out of all of these causes, if they ask you to select one for the post-renal variety, your answer would be given as benign prostatic hyperplasia. And next, I'll explain to you why would patients of acute kidney injury present to you. You see, once the urea levels will begin to rise, it will irritate the stomach mucosa. So most patients initially would be hypochloremic, that is nausea and vomiting would be present. Then elevated urea in the body will also irritate the diaphragm, and therefore patients would be having hiccups, which would be difficult to manage medically. Because of the progressive decline in the glomerular filtration rate over a matter of couple of hours, the RAS system will be activated and the blood pressure will shoot up very fast to the level that the person can be having a hypertensive crisis or a hypertensive encephalopathy. So acute kidney injury can contribute to loss of consciousness in an individual, not only because the person will develop a uremic encephalopathy, but even hypertensive crisis could be contributing to that unconsciousness in the patient. Because there would be a volume expansion, the RAS system is working overtime, aldosterone values are increasing, and the person at this moment, while he's going into kidney injury, his relatives would still be making him drink water, because in India it's gonna be hot, so person is drinking water, input is there but output is not there. Plus the aldosterone values are increasing in the person, so there is a substantial volume expansion because the water has to be excreted out by the kidney and the kidney is not doing its job. So patients of acute kidney injury will start developing pedal edema, and the volume expansion can be so much that these patients could be experiencing breathing difficulty as well, pulmonary edema, which explains why crepitations can be felt in the lungs of patients of acute kidney injury. Oliguria would then ensue. Urine output less than 400 ml is oliguria, and then person will develop anuria, which would be urine output less than 100 ml in a 24-hour basis. We'll talk about how to and how much amount of fluid and which fluid to be given to a patient of acute kidney injury. But once the kidneys are shutting down, you also need to get into the causes. So when I'm trying to talk to the patient or to the patient's relative, I shall also be taking a history with respect to what medications patient was taking in the previous 1 week or so, because if a person is taking drugs and then there's an acute kidney injury, then I'm not only talking about ACE inhibitors or angiotensin receptor blockers, which could be contributing to acute kidney injury in people who are having a low renal reserve, or about non-steroidal anti-inflammatory drugs, but I'm even talking about PPIs. I'm also talking about antibiotics, because I taught you about acute interstitial nephritis, AIN, where eosinophiluria can be present and acute kidney injury could be occurring. If a person has had a bout of diarrhea, past medical history will also matter, because if he had a bout of diarrhea followed by dehydration, then the diagnosis becomes pretty straightforward. But do look for the fact that is he mentioning regarding a unilateral renal enlargement, which means that he's trying to guide you towards renal vein thrombosis per se. Then apart from past medical history, I'll also ask whether, apart from the diarrhea component, whether patient underwent any contrast study, because if a person has undergone a contrast study, then we could be thinking in terms of a contrast induced nephropathy, or for that matter of fact, if he mentions that after contrast study livedo reticularis was present, eosinophiluria was present, it could be atherombotic kidney disease. I'll also quiz regarding flank pain, because stones could also contribute to post-renal variety of acute kidney injury. I'll ask what symptoms of dribbling of urine when the patient is straining, especially with respect to prostatism or obstructive uropathy caused by benign prostatic hyperplasia. So, past medical history would incorporate multiple things. I said not only something like a recent episode of diarrhea, where I could be thinking about HUS, or a standard acute kidney injury, but a contrast-based study, history, flank pain, obstructive uropathy, autoimmune disorders, because a lot of patients could be having like lupus nephritis, the renal reserve is low, and then acute kidney injury can be superimposed on a chronic kidney disease in a patient. And then type 2 diabetes is so common in India, they could be having low renal reserve due to diabetic nephropathy, and acute kidney injury can be overlapping this. Apart from this, we'll also look for and quiz regarding complications of uremia. The person's breath will smell bad. The breath of the person will smell like urine. That would be uremic fetor. And apart from this, person can be having uremic pericarditis. The incidence of bleeding is always increased because toxins that accumulate interfere with platelet function. So bleeding can occur in these patients, and that bleeding can not only occur, from an IV cannula side. The bleeding could be even in the pericardial space, because person is having a uremic pericarditis. So if he bleeds into the pericardial space, cardiac tamponade can occur. And then you could have asterixis developing in a patient, myoclonus in a patient. There could be development of encephalopathy as well. So these are a couple of pointers that will tell you regarding the acute presentation of the case. And then you'll also quiz regarding some of the pointers that were triggering this acute event in an individual. And once you have evaluated the patient from the clinical grounds, you will do is a workup where we'll talk about electrolytes, we'll talk about the derangements that can be seen in patients of acute kidney injury. Coming to the workup of the patient, you want to write a KFT, the urea and the creatinine of the patient would be grossly elevated, and then you are going to have a look at the electrolytes. There are a couple of specific electrolyte imbalances which are always asked in the exam. One of them is going to be hyponatremia. The reason for this hyponatremia would be that there is an increased aldosterone, which will contribute to more body water as well as more salt in the body. The total body water will also be more, and total body salt will also be more. So the description that I've even given in the electrolyte segment for acute kidney injury or a chronic kidney injury patient would be hypervolemic hyponatremia. The reason for this hyponatremia is the dilution component, because the amount of water in the body is disproportionately in excess to the excess amount of salt. Agreed salt is more, but body water is even more. I can just write it like this. TBW is total body water. I put two arrows in front of it. Total body salt is also increased. I put a single arrow to it. The disproportionate increase in water explains why I have written hyponatremia, which will respond to most of the time fluid restriction. Kidney is responsible for excretion of potassium. Once kidney shuts down, potassium can go up to 7, 8 life-threatening values that can cause even a cardiac arrest in the person. Because these patients would be having vomiting, therefore chloride values would most of the time be reduced. This is important for you to know, because if a person is having hypochloride values, the normal saline is the fluid that would be recommended in these patients subsequently, so that I can bring these chloride values back to normal. But if chloride values are normal, I can use ringer lactate as well. I'll talk about when should you give normal saline, when should you give ringer lactate. Yes, you can give ringer lactate in patients of kidney injury. Agreed, ringer lactate will have potassium, but at the same time it will provide lactate also. That lactate will neutralize the acidosis. You see, you can't win a war. There will always be collateral damage. So I know that your query will be, sir, ringer lactate, I mean, come on sir, potassium is elevated, you giving. I am saying if potassium is 7.58, I'll not give ringer lactate. If life-threatening hyperkalemia is that, I'll not give ringer lactate. But if it's not life-threatening at the moment, I can give ringer lactate, because at least it will treat the acidosis component. So I'll speak more about the normal saline and the ringer lactate. What should you choose for the patient based on the electrolyte values? I told you if chloride is less, he says normal saline. If chloride is normal, then you can give ringer lactate in the patient as well. The next point is usually forgotten but should be remembered. Phosphate is elevated both in chronic kidney disease as well as in acute kidney disease. Therefore, we shall be giving phosphate binders in these patients as well, like sibalimer or calcium acetate or aluminum hydroxylate can also be tried. And because phosphate will bind to calcium, so the calcium values could be lesser. So these are common electrolyte imbalances which could be deranged in these patients. And then over and above this, you also need to have a look at the uric acid values. I've written that in bracket because uric acid will show a gross elevation in a person who's having tumor lysis syndrome, because the crystals of uric acid will be blocking the tubules. And if he's going to give you a situation of tumor lysis syndrome, then the question will describe, the examiner will tell you a situation that chemotherapy was instituted in a patient of Burkitt's lymphoma, or a cancer having a high turnover rate. Aggressive cancer like tumor, like Burkitt's lymphoma, acute lymphoblastic leukemia, when you kill those millions and trillions of cancer cells simultaneously, that's when the uric acid values in the patient will increase. So with electrolytes, uric acid is also to be considered. Then you'll be doing ABG in this patient. The objective of doing ABG would be to pick up metabolic acidosis. It would be a high anion gap metabolic acidosis or HAGMA seen in the patient. For the ABG report, you need to remember when would you like to treat the patient when the pH of a acute kidney injury patient is less than 7.2 and the serum bicarbonate values are less than 15. That's when you're going to say that, okay, person is suffering from high anion gap metabolic acidosis. You will have to institute soda bicarbonate in these patients. How do you calculate, soda bicarbonate correction? I'll mention a formula before you. This formula that I'm telling you is also discussed in the electrolyte section, but let's do a quick repetition. You need to multiply the weight of an individual by 0.5 and then you need to multiply this by 24. 24 is the actual value that you want to obtain. That's the ideal value that I want to obtain in the patient, and whatever be the actual value given in the MCQ, you need to subtract from it. Just for the sake of discussion, suppose he gives me a scenario of a 60-year-old lady. He could mention a man as well. Gender here will not make any difference. And he says that this person has gone into acute kidney injury. When the ABG of the patient was done, the bicarbonate values, let me say 15 only. And he's saying calculate the soda bicarbonate which is required for this person. Whenever they give you a mathematical question in the exam, it will always be a one-step multiplication or a one-step division. Like in this case, it will be one-step multiplication. That is, you need to multiply 30 by additional value of 9 and you will have the answer. So most of the time, and this soda bicarbonate correction that I'm telling you will be over 24 hours. We don't give the entire dose simultaneously. Half of this will be given over 8 hours and the remaining over 16 hours. Just like in burns, no, you give some amount of fluid over 8 hours, some over the next 16 hours. Whatever value that you will get here, you will not give it simultaneously. It would be divided into two parts. The first part would be given over 8 hours and the subsequent part would be given over 16 hours. So metabolic acidosis needs to be treated. If in spite of treatment, in spite of the drugs that have soda bicarbonate was given and still the pH is less than 7.1, then it would be an indication for dialysis. So as we progress in the discussion, we'll draw up a list for indications for hemodialysis, but one of them is going to be metabolic acidosis not responding to medical therapy. When the correction has been given, but the pH is still less than 7.1. Then we'll also be doing a urinary microscopic examination in the patient. The advantage of this would be that specific findings can be picked up. Let's just quickly practice those findings from the exam perspective. Like he could mention regarding muddy brown granular cast. This could be a one-liner question also. Muddy brown granular cast would be encountered in, and I am leaving this at the moment for you guys to figure out what is the answer before I write another one. Because if a person is having, let me say, acute glomerulonephritis, then he's going to describe dysmorphic RBCs. See, the RBCs will change their shape when they have to filter across the glomerulus under duress of high pressure. The intraglomerular pressure would be increased because of a higher immune state. Another finding that could be described is eosinophiluria. I've given you situations for eosinophiluria already, but let's just practice this here. Good way to, just remember data. Muddy brown granular cast, you will answer for acute tubular necrosis. Dysmorphic RBCs would be a feature of acute glomerulonephritis. If he says eosinophiluria in a patient, then the following causes are to be remembered: atherombotic kidney disease and acute interstitial nephritis, which we'll talk about fever, rash in an individual as well, along with the renal shutdown. And then I want to tell you that even pyelonephritis. In pyelonephritis, there are pus cells present. Pus cells means white cells present, white blood cells present. So with white blood cells, eosinophils can also be present. And similarly, in acute glomerulonephritis, when blood will come along with RBCs, some neutrophils can also come and some eosinophils can also come. So do not be surprised if you read about eosinophiluria in glomerulonephritis and pyelonephritis, because after all, white blood cells can be present in the sediment in even the true conditions, and therefore eosinophiluria could be present. I have not written schistosomiasis here because we are talking about acute kidney injury. Schistosomiasis is a parasitic infestation that can cause a hematuria but does not result in acute kidney injury, which is the reason why when you read causes of eosinophiluria, parasitic infestation will also be mentioned, schistosomiasis, but not mentioned here because we are not talking about acute kidney injury. The next investigation that I'll be writing for this patient would be a urine osmolarity. Along with this, I'll also be checking urinary sodium. And based on these urinary sodium values, we shall also be calculating what is called as FeNA, that is fractional excretion of sodium. Now, what I say next, I want you to just listen to it at the moment. This crude diagram represents afferent arteriole. This is the efferent arteriole, which would be feeding the glomerulus. And then we have shown the tubule present here, and my patient is suffering from diarrhea. If a child is suffering from rice water stool, is suffering from diarrhea, therefore the flow into the afferent arteriole will be less. Because the body is having less flow, therefore the body will try to conserve whatever salt is coming in the proximal convoluted tubule, because maximum absorption of salt occurs in the proximal tubule. So in this diagram, I've tried to show that the reabsorption of sodium, there's a transporter, you know about it, SGLT2, sodium glucose link transporter. So the salt reabsorption will be increased. Now the question of mine to you guys is, let's have some participation. What is going to happen to urinary sodium in a person with diarrhea? Because water will also be reabsorbed, salt, everything is going back. So urinary sodium in this patient will be relatively low. Let's compare this with another situation. Once again, afferent arteriole. This is the efferent arteriole, glomerulus and the tubules. And this time what I'm saying is that the problem is not with the flow in the afferent arteriole or flow in the efferent arteriole, but the cells of the proximal convoluted tubule are getting damaged. It's a tubular damage. My patient is suffering from ischemic variety of acute tubular necrosis, like he had a prolonged anesthesia, prolonged hypotension, because of which the blood supply of the medulla has been hampered. The blood supply, the proximal, I told you, S3 segment of proximal convoluted tubule is the most vulnerable ischemia prone segment of the kidney, which is present in the outer medulla. So I put crosses here to say that now the reabsorption of sodium would not take place. I mean, the sodium or the salt was supposed to get reabsorbed from this area, but I put a cross to say that the ability to reabsorb here is hampered because the cells are damaged. Therefore, if you're gonna check the urinary sodium in these patients who are suffering from ischemic variety of acute tubular necrosis, because salt will not be absorbed, urinary sodium would be relatively high. From this, you can work out that the term FeNA, fractional excretion of sodium, the word is low. So remember, the value will be less than 1%. And for the renal variety, that is ischemic ATN, the FeNA value will be more than 1%. That's a basic rule to be remembered, because lots of time they're going to mention a table, and in the parameters urinary sodium FeNA will be written. So when it comes to pre-renal variety, that is like a case of diarrhea, because everything is going back, low urinary sodium, that is why FeNA is on the lower side. The arrow is going towards, the direction of this arrow is towards the lower side. And because urinary sodium is high, FeNA would be relatively on the higher side. We can also mention regarding urine osmolality, then urine osmolality with respect to the left side, because urine will be relatively concentrated. So look at the value that I put up, something in the range of 500. But in the ischemic variety, the value that I put up for urine osmolality, that's what is usually seen is 300 milliosmoles. The logic again is that in diarrhea, there is going to be concentrated urine. Water is getting lost from the body, because water is getting lost from the body in the form of diarrhea. So kidney will try to conserve, and due to this conservation, urinary sodium will be increased. But because the tubular cells are getting hampered here, so water absorption is also hampered, and therefore the urinary osmolality will be relatively lower. So one test that helps us identify, it's not a very accurate test per se, but yes, it helps us differentiate between the renal and the pre-renal variety, is going to be answered as fractional excretion of sodium. However, the values of fractional excretion of sodium, that is FeNA values, can be falsely low. The value will turn out to be lesser in couple of renal causes. I told you FeNA is more than 1 in renal cause. Like I told you, ischemic ATN FeNA was more than 1%, but this value can be falsely low in acute glomerulonephritis, or in cases of contrast-induced nephropathy, or in rhabdomyolysis. And let me now give you the reason, because all of these that I've explained to you are renal causes of acute kidney injury. So FeNA should be high, but will turn out to be lower. If I take up the case of acute glomerulonephritis, the damage is in the glomerulus. Damage is not in the tubules. So if the tubules are still working, see, in ischemic variety, I had put some crosses here to say that the tubules were damaged. So tubules were not able to reabsorb the salt. But in acute glomerulonephritis, which is a renal cause, but the problem is not in the tubules. I mean, the tubules are working perfectly fine. The tubule cells can reabsorb the salt, because the reabsorption can occur, value can turn out to be less than 1. And therefore, this thing that I was telling you, that it's very easy to differentiate between pre-renal to renal, it's not all that easy. Yeah, you will use clinical information also. I mean, acute glomerulonephritis will have RBC cast present. Contrast-induced nephropathy will have a history of a procedure being done in a patient. Pre and post keratin values will also be given in a question. But what I'm trying to tell you is that FeNA is not an ideal way. It is a good way, but not an ideal way to differentiate. In fact, we don't have an ideal way to differentiate pre-renal and the renal causes. The values are lesser in acute glomerulonephritis because tubular cells are perfectly normal, so they can reabsorb the salt. Because the salt will go back again, and therefore the values will turn out to be lesser, though it was a renal cause. Then comes contrast-induced nephropathy. In contrast-induced nephropathy, the contrast is blocking the tubules. Tubular cells are fine. Similarly, in rhabdomyolysis, that is myoglobin that is clogging the tubules, but tubular cells are working. So my point is, guys, when it comes to these three conditions, though these are renal causes for development of acute kidney injury, you have to understand this fact that this table will have some flaws. Whatever I said here before you, this table helps us differentiate between a pre-renal variety. I said helps, but it is not a sure shot diagnosis. So you should be aware of the fallacies. I mean, every time we try to simplify things, there can be some problems with, because this is an artificial classification we have created. No, I mean, a disease will not go by classification. You see, the query of yours would be, sir, it's very confusing. What do we remember? First, you need to remember this table. Then you need to remember the exception to the table. The exception to the table is renal causes which contribute to FeNA less than 1%, because traditional teaching is FeNA is, I'll repeat that again, traditional teaching is FeNA is always fractional excretion of sodium, more than 1 is for ischemic variety of ATN. So the impression is in all renal causes this is going to happen. No, because disease is not going to follow this classification. Disease will do its, it will follow its own course. I've told you five investigations till now. So the sixth one that I'll tell you would be an ultrasound. And why am I doing an ultrasound is mainly to rule out the post-renal causes of acute kidney injury. And as I've told you, I mean, if it's gonna be like not visible, like a ureteric bilateral stone, not visible on ultrasound, I can do a CT as well. Coagulogram should be done in these patients of AKI because bleeding tendency is enhanced in these patients. We'll also talk about desmopressin being used. Yes, desmopressin that we use even in von Willebrand disease for control of bleeding in patients of uremia. Once uremic encephalopathy starts developing, bleeding manifestations can also occur. Then because sepsis is one of the causes, so I have written blood culture to be done. Then a rare cause that I mentioned was thrombotic thrombocytopenic purpura, where ADAM TS13 activity was less. So von Willebrand factor activity was unchecked, and therefore microthrombi in the blood vessels, in the lung circulation, and in the kidney circulation and brain circulation were getting formed. So ADAM TS13 levels are being checked for thrombotic thrombocytopenic purpura. I will also do an autoimmune panel in the patient because scleroderma crisis. Remember, in rheumat, I've described a connective tissue disorder by the name of scleroderma. Scleroderma can cause fibrosis of the kidneys and can result in severe hypertension. The term is scleroderma crisis. I'll tell you what is to be done in management of scleroderma crisis, but remember, scleroderma can cause fibrosis of kidneys and can contribute to extremely high hypertension. And even in those patients, the KFT can be deranged because the kidneys are getting affected. For rhabdomyolysis, CPK-MM levels will be done and would be grossly elevated. The usual description for rhabdomyolysis, where CPK-MM would be elevated, would be a T color urine. I mean, like we read about T color stool being passed in VIPoma, vasoactive intestinal polypeptide, T color stool being passed. I mean, like you boil tea, the Indian tea will have milk in it also. But what I am saying is that if you are reading tea color stool, watery stool, up to 700, 800 ml per day, then it is VIPoma. I mean, one of the causes can be VIPoma. Where say tea color urine is a feature that you read with rhabdomyolysis. So these are the investigations that would be done to evaluate a patient of acute kidney injury. And I repeat once again, in thrombotic thrombocytopenic purpura, it is the I think there was a misspelling. I was trying to speak faster. The term to be remembered by you is that the kidney circulation and the brain circulation is affected. That's why neurological features of stroke can be seen in thrombotic thrombocytopenic purpura. We shall now talk about treatment of a patient of acute kidney injury, where the first priority would be fluid balance. We'll be determining the insensible losses from the body, which is about 800 ml per day. You see, insensible losses that occur would be from two areas, like when I'm speaking before you, or even if I'm not speaking, if I'm quiet and I'm doing a quiet breathing, then water will be lost from my respiratory tract in the form of water vapor. And then we also lose water from our skin. So transepidermal loss also occurs, which is a range of about 800 to 900 ml. So I've written 800 ml per day. Plus I'm doing an input output charting in the patient as well. What I mean here is that how much fluid should I give to the patient? The orders of mine for the next 24 hours would not be the traditional 4 to 1 formula that we, or the 4 to 1 rule that we use. What we'll do here will be urine output plus insensible losses. So suppose in a person of acute kidney injury, the urine output from the previous 24 hours is documented by your nurse to be only 100 ml in last 24 hours. We had put up a condom cath in the patient, or we had catheterized the patient. The urine output was only 100 ml and the insensible losses is 800 ml. So you need to give 900 ml of fluid to the patient in the next 24 hours, because I want to prevent volume expansion. I mean, if I give too much of fluids, volume expansion is already present, it will worsen. Then would be what fluid should be given to the patient. Then he says that check out the electrolytes in most of the patients, because there would be some vomiting component due to urea irritating the stomach mucosa. Because chloride is lesser, you can give normal saline to the patient. But he says that if the chloride values are normal, then you can give ringer lactate. And I know that I broached this topic earlier also. When the woman has a ringer lactate, Carissa ringer lactate contains potassium. Potassium is elevated in AKI. You see, in ringer lactate, the advantage is also there that the lactate will be metabolized by the liver to produce bicarbonate, and this bicarbonate will then help you neutralize the acidosis component, because protons which are being produced here, or the protons in excess in AKI, they can damage the blood-brain barrier and cause a cerebral edema. So I also want to neutralize the acidosis component, and the advantage of acidosis will be that it will also help in, or it improves potassium values. See, I have described this in the electrolytes video that pH is inversely related to potassium. So if you will get potassium back, if you will ensure that pH goes back to normal, because you will neutralize the acidosis, so pH will go back from 7.25 to 7.35, and therefore not only does, correction of acidosis benefit the patient, it improves the potassium levels as well. And at the same time, I can say the only disadvantage is that ringer lactate contains some amount, about 4 millimoles per liter of potassium. So that disadvantage is there in a sense that you cannot use it if the potassium values are going in life-threatening range. I don't think so that there'll be a question where they'll make you select between normal saline and ringer lactate, because this is how it's given in Harrison. Low chloride values in majority of cases. So he says normal saline, if chloride is normal, it is ringer lactate. So this situation should be given because textbooks are used as a guide to creation of questions. Additional fact I can say is he might say that you can add soda bicarbonate to normal saline. That is alkalinization. Alkalinization is occurring, or I can say when you are adding soda bicarbonate to normal saline and then giving it in the form of an infusion to a patient, then we call it forced alkaline diuresis. And in which situation would you be preferring this soda? Not only neutralizing the acidosis component, but where would you do a forced alkaline diuresis? So this is recommended in rhabdomyolysis. Like this guy was having a T color urine output following the prolonged immobilization or after status epilepticus. It may not always be a car accident. He might give you situations of malignant hyperthermia, then a T color urine being passed by a patient. So to prevent the tubular injury, he says that alkalinization of the urine by adding soda, alkalinization of the fluid that we are giving to the patient will prevent, because this alkali will finally come in the ultrafiltrate also, because you have given it in the blood. So it will prevent the tubular injury which can be encountered in rhabdomyolysis. There are 3 points for the fluids that I've told you. How much to give? How much to give will depend upon urine output plus insensible losses. What fluid, what type of fluid will be given? So normal saline and ringer lactate, either the two as the situation will be. And when would you do a forced alkaline diuresis? That is to prevent tubular damage once rhabdomyolysis has set up in the patient and the CPK mm values in the person are spiking. In some MCQs, he may not mention T color urine, he might just say red color urine. Yes, in rhabdomyolysis, initially the color can be reddish also. Now coming to the second point, the drug that will be starting for diuresis in the patient would be furosemide. You're not expected to remember dosages, but we give about 200 milligrams initially as a bolus, and then subsequently we can convert this in the form of a drip. The usual dose in the drip would be about 10 to 40 milligram per hour, and the bolus can go up to 200 milligrams as I explained. The third aspect to be done is handle the metabolic acidosis of this patient by giving soda bicarbonate. The formula I'll repeat once again. For the correction of metabolic acidosis, you need to use or remember this formula. That would be a target value of 24 minus whatever is the value given in the question. It would be a one-step multiplication. I've already done in the numerical format before you. And do remember that the entire soda bicarbonate should not be given simultaneously. It can result in overcorrection as well. In fact, if you overcorrect, then it will cause metabolic alkalosis. And if you overcorrect and cause metabolic alkalosis in a patient, then in the electrolytes topic, I have explained that metabolic alkalosis causes a redistribution of calcium. That redistribution of calcium can then result in development of hypocalcemia in these patients. So to prevent the development of tetany, to prevent the development of hypocalcemia, overcorrection resulting in metabolic alkalosis is to be prevented. The next problem that is encountered in these patients is that of hyponatremia. That's because of hypervolemic hyponatremia. This responds usually very well to fluid restriction. So person would not be allowed any fluids orally. It will just be IV fluids that would be given based on urine output and the insensible losses as I explained to you. The potassium values of this person will rise. You see lots of time in India when somebody is sick, even if it is very poor patient, no family member will go outside the hospital to some juice stall, so some fruit vendor, and then they'll get a fruit juice for the person. You would have seen, no, lots of poor patients. When somebody is sick in the house, they'll go and get some juice for the family member because they think that okay, it will be beneficial. And if you give fruit juice to somebody who's having elevated potassium, the values would rise even further. So you need to restrict coconut water for that matter of fact. So restrict dietary intake of potassium. That is one. Even the diet of this patient subsequently when he recovers, it has to be carefully ensured that the potassium values don't spike up due to dietary reasons in this person. Then a lot of these patients might be hypertensive already. In any hypertensive patient, if he's on ramipril or any other ACE inhibitor or angiotensin receptor blocker like telmisartan, then they have to be stopped because the side effect with ACE inhibitor and ARB is hyperkalemia. Then is the standard management of hyperkalemia. Like if he says life-threatening hyperkalemia, then I'll not talk about dietary intake. If it's a life-threatening hyperkalemia, I'll talk about calcium gluconate. I will talk about insulin drip, 10 units, 10 international units to be given to the patient in mixed with 50 ml or 50% dextrose in the form of an infusion. And along with this, we'll talk about salbutamol nebulization. And furosemide I'm not writing because furosemide is used in management of hyperkalemia, but we have already given it in part number 2 of our discussion. Because these patients will also be having hyperphosphatemia. So if he says, how do you manage it? Apart from the dietary restriction component, we need to give phosphate binders to these patients. Now let's just revise those phosphate binders that have been discussed even in the chronic kidney disease chapter. In patients who are having hyperphosphatemia, when I was teaching you CKD, I was telling you mainly sevelamer as the initial approach. But in this particular case, we can be using calcium acetate as well. In calcium acetate, the problem in CKD was that it can contribute to problems like tumoral calcinosis to worsen actually. So in a CKD case, primarily first answer phosphate binder as sevelamer. But in a person of acute kidney injury, we can be using calcium acetate for management as well, or we can even use aluminum hydroxide. After a long time, I'm writing a chemistry formula, aluminum hydroxide, which can be given with meals, and this would be a phosphate binder. Calcium most of the time is, hypocalcemia, even if it is present in AK, is usually asymptomatic, so nothing needs to be done. Only if it is a symptomatic hypocalcemia, that 10% calcium gluconate should be administered to the patient, which is the reason that I'm not writing anything with respect to calcium, though I did mention asymptomatic, no need. If it is symptomatic, then 10% calcium gluconate would be given. We also need to manage the hypertension of these patients. In fact, the BP can increase to dramatically high values and he can end up with hypertensive crisis. The drug that we can use to get him out of this hypertensive encephalopathy state due to hypertensive crisis can be labetalol. Make no mistake that if in the question he mentions that she is a known case of connective tissue disorder, scleroderma, and her KFT is deranged and the person has become unconscious, possibilities she is in scleroderma crisis. The scleroderma crisis, which is present in this autoimmune disorder, we have to use ACE inhibitors with a watch on potassium. So do remember that if he specifies the word scleroderma crisis, then there is no need of giving IV labetalol. Then answer is ACE inhibitor, but with a watch on potassium. But otherwise, if he just says hypertensive crisis, then labetalol is sufficient, because there can be increased risk of bleeding in patients of CKD because the function of the platelets can be hampered and interaction with the von Willebrand factor can also be hampered. So what we can do in these patients for management purposes is use of desmopressin. Traditionally, we read about desmopressin being used even in hemophilia patients for non-life-threatening injuries and even in von Willebrand disease. But today I'm telling you that we can use it in CKD patients also for minor bleeds. Apart from this, if the bleeding is very extensive, though he does talk about estrogens also being used, but if the bleeding is extensive, then he says that the chances of this bleed occurring in the pericardial space is high. I said that earlier also. They can have uremic pericarditis, bleed into pericardial space. So then hemodialysis would be recommended. So we will here once again practice what are the indications for doing hemodialysis in a patient who's having acute kidney injury or acute kidney injury superimposed on chronic kidney injury. Then the mnemonic to be remembered for this is AEIOU, and let's just practice it. Alphabet A would be standing for metabolic acidosis developing in a patient. He says that the pH of the patient is less than 7.1, and you have already given soda bicarbonate correction to this patient not once but maybe twice, and in spite of the correction being given to the patient in the previous 48 hours, the acidosis component is still persisting in this patient. Alphabet E is easy to comprehend, electrolyte imbalance. The electrolyte imbalance that we're talking about in this case is dangerous hyperkalemia. I mean, which is persisting in spite of the correction. Like we have given calcium gluconate insulin drip to the patient, but in spite of using the best drugs, there is still a problem. I would be more valid for the CKD topic, that is renal insufficiency. Like if we document estimated GFR of a person in CKD to be less than 10 ml per minute, that is much lesser than the value of renal failure or end stage kidney disease, which was less than 15, then dialysis in the patient is to be instituted. Alphabet O would stand for volume overload. This volume overload again needs to be corrected, because if not corrected, then it can contribute to pulmonary edema. It can worsen the hypertensive crisis of the patient. Now for this volume overload, I'll again mention that in spite of medication, like you have used furosemide in the patient, high dosages, drip of furosemide was also given, but the volume overload is not responding to it, then you need to do hemodialysis. Alphabet U would be standing for uremic complications. The first one, if we ask you to select one, I mean, out of all of them that I'm writing, if they ask you to select one, absolute indication for doing a hemodialysis, your answer is uremic pericarditis. Apart from this, even uremic encephalopathy, there could be a cerebral edema component developing in a person. So these are a couple of indications for performing hemodialysis. Now, unlike hemodialysis, which is done in CKD patients, where we create a fistula between the radial artery and the cephalic vein, that is the breccia semina fistula, in persons who are having acute kidney injury, there is no need for creating a fistula. Rather, what we'll do in these patients would be that we'll be doing intermittent hemodialysis. So for intermittent hemodialysis to be performed in these patients, we obviously need to go ahead with a vascular access. The vascular access that we'll be using in this particular case for intermittent hemodialysis should be answered by you as internal jugular vein, or we can use subclavian vein, or we can even use the femoral vein. So the message here is that in patients of CKD, because dialysis has to be done 3 times per week, every session is 4 hours, multiple episodes are multiple hemodialysis sessions are required in CKD. In this particular case, you might require dialysis maybe twice, maybe thrice, and the person's kidney will recover. Kidney has tremendous powers of recovery. So because you are requiring dialysis maybe only a couple of times, so you will put a double lumen catheter. The double lumen catheter can be put in the internal jugular vein, it can be put in the subclavian vein, it can obviously be, there would be some, hygiene issues with respect to the femoral vein. But my point is, we plan to do an intermittent hemodialysis to get rid of this problem, and in majority of cases, the person will show a good recovery. Now, what is flowing into the hemodialysis? I mean, I'll use a casual word that I can say the word filter, in a sense that like we can correlate with the filter that we have in our house. So on one side, it would be the blood of the patient. On the other side would be the dialysate, and both of them will not be moving in the same direction. I mean, the movement of the blood and the movement of the dialysate is going to be opposite. They utilize countercurrent mechanism to facilitate solute diffusion. You see, one of the primary principles of hemodialysis is solute diffusion. So there are a couple of harmless products present here. The harmless products are like urea, creatinine, potassium. So all these are the bad guys, and I want to lose them. So the holes in the filter, or I can say the dialyzer, are designed in such a fashion that the bad guys can move across. In contrast, we have a couple of good guys present in the dialysate fluid, which will move in opposite direction across the gradient, that is bicarbonate. This bicarbonate will help in neutralization of the acid. So we're getting rid of the toxic products, but at the same time, I don't want to lose. I mean, the holes in the dialyzer or the filter, which I'm saying casually, the dialyzer, are designed in such a fashion that I don't want to lose RBCs. I don't want to lose proteins. The red dot that I've shown is for proteins, and then I have shown red blood cells. So the dialyzer is designed in the dialyzer membrane is designed in such a fashion, it's biocompatible, and it's designed in such a fashion the bad things are lost, the good things would obviously move across in opposite direction, which will neutralize acidosis, and then some of them would be retained. You see, it's not only about urea, creatinine, there are many, about 60 toxins that accumulate in the body in a person who's having acute kidney injury or chronic kidney injury. So urea, creatinine is just surrogate markers that we are talking about. And intermittent hemodialysis for a few hours would help in recovery of the kidney function of these patients to normal. Here I can also ask you, what is the most common complication that is seen with hemodialysis? Then overall, the most common complication of hemodialysis will be hypotension. And therefore the question arises, what are we going to be doing if a person is having hypotension or if he is having hemodynamic instability? Then we will not be able to do intermittent hemodialysis. So let's now look at what strategies would be used in those patients who are having hemodynamic instability, that what is the alternative approach in place of intermittent hemodialysis which can be used. So in this hemodynamically unstable patients, the technique that we are going to use is called as continuous veno-venous hemofiltration. We call it continuous because this process would be spread over 24 hours. In intermittent hemodialysis, the session of hemodialysis was only 4 hours via double lumen catheter. Whether I need to repeat the intermittent hemodialysis will be based on the KFT report and the ABG report of the person, and will obviously based on nephrologist's decision. But in continuous veno-venous hemofiltration, which is done in hemodynamically unstable patients, the process would be longer, over 24 hours. The principle of CVVH would be convective clearance. Convective clearance would mean that we're removing water as well as dissolved solutes across a semi-permeable membrane, and then we also add a replacement fluid back into the blood circulation, where we do not add any replacement fluid to the blood circulation in case of hemodialysis, but here a replacement fluid is also added and is called as CVVH. Next, what I'm teaching you is a hybrid technique, that is CVVHD. This is continuous veno-venous hemodiafiltration. CVVHDF is a combination of CVVH plus dialysis. I mean, in dialysis, as you can see, we don't add any fluid to the body. Here we are adding a replacement fluid, plus we are doing dialysis in the patient also. So this is a hybrid technique that would be over a longer duration. And most of the time, if he's going to put up a question on CVVH or CVVHDF, the question would be, when would you be doing it? I mean, that is only for those patients who cannot tolerate hemodialysis or are hemodynamically unstable. So your answer would be hemodynamic instability, cerebral edema, or I would say extensive volume overloading present in a person where we need to remove a large amount of water. We can do is a hemofiltration, where the excess amount of water and the dissolved solutes and the toxins can be removed. So these are the details that I would like you to remember for this topic. It took a while for me to cover this, but I hope that it will be worth the effort. So keep the pressure on, keep hammering, guys, and you will definitely break on to the other side. And what I mean is, you will get good ranks. Thank you so much.